in orthopedics. So I have 3 functioning neurons, 2 of which are involved in standing upright. Isn't that right, Brendan? Yeah, that is the stereotype. But any of you who have read the BMJ journal, any anaesthetists here? Yes, yes. Even though they say that we are strong as an ox and twice as intelligent, the BMJ article proved that we were more intelligent and stronger than your average anaesthetist. So there. Now, I want to ask you guys a question. I want a show of hands because obviously we have a very differentiated group of people here. How many of you are consultants in hospital practice? How many of you are in hospital practice? Okay. How many of you are in primary care or public health or non-hospital practice? Okay, so that corner of the room, yeah, we'll mark you out for special attention. And how many of you are not in active clinical practice at the moment? Okay. And then how many of you are retired and might be facing challenges with doing an audit? Okay, so good smattering of people. Right, so we have a very broad group of people here. So I'm going to try and talk to you about clinical audit and how to make it easy, efficient, and interesting. The last bit could be a bit of a challenge, but we'll have a go at it, all right? I want some volunteers to come up with challenges that they face in doing clinical audit. Who's willing to shoot first? Yeah.
Collecting data.
Collecting data. So, yeah. Here, I've turned it slightly this way. Yeah. Sorry, yourself? Yeah. Okay, so getting everybody around the table, so involvement, yeah. You realize what a challenge it is for an orthopod to write while standing up and talk at the same time? Yeah. Anybody else? Relevant, yeah. And I heard somebody say retired. Yeah. Yeah. There's always a solution to every problem. It's just a case of thinking laterally to it. So we'll come back to that because a lot of people worry about that question. But if I don't address it enough, chase me on it. Re-auditing, yes.
Okay. I have patients, but I don't have any clinical patients.
Yeah.
I work in the Department of Social Protection. So,
oh.
So I'm not trying to cure them. I'm not trying to make them work.
Yeah. So it's how would I say, indirect contact or indirect care. All right, grand. Yeah.
Working as locum.
Okay, so your movement, you're an itinerant doctor. Yeah. So moving from A to B. Okay, grand. There's actually, that's easy enough one to deal with, yeah? New topic. So what? Yeah? Yeah? Okay. Change. Grand. You're on a roll. You're doing very well. I'll give you 7 out of 10 so far.
Another issue is the separation of audit from quality improvement.
Uh-huh.
How could we have a
Yeah. Audit versus, yes, and versus research as well, because they are 3 sides, if you imagine that, of the one coin. And sometimes these distinctions are artificial distinctions, but they have a benefit at certain times. Yes? Ethical approval. Yes, grand. So ethics. Grand, yeah.
Objectivity.
Okay. I told you weren't asked questions like that. But that is actually a very, very good question. And we'll we'll address it in, hopefully. We have a lot of things to address, yeah? So the voluntary nature. Of course you're doing it voluntarily, aren't you? Yeah. Okay, we have a lot of topics to cover there. And in this brief time, we're going to have a go at trying to cover them. So I'm going to go through a few bits and pieces next, and then we'll chat about some of those. But I'm starting off with a quotation. I haven't done this one before, but it's obviously, there's a certain logo in it which betrays its origin, but it's about the integrity of design. And for those of you who use smartphones, but particularly those of you who are in the Apple landscape, you will know that he charges huge amounts of money for something that's very, very simple. But the interesting thing about it is the simplicity is part of what makes it good. And you shouldn't have to explain something in more than words of one syllable. If it's not explainable like that, it's too complicated for everyday use. And that's why I want to put that up here in terms of talking about clinical audit and making it simple enough that, for instance, if you give a smartphone to somebody, they can fairly intuitively work out how to use it. Now, that's not projecting terribly well, but some of the things that we might cover is the why, what makes for good audit, what makes for data management, which somebody brought up earlier on, and then the challenges that are going to be intermingled with all of that. So essentially, the obstacles, the recipe, the warnings, and the challenges. How many of you have read Alice in Wonderland? Come on, now's the time for you to shed your embarrassment and fess up to it. Yes, good. I'm glad to see, yes. And come on, there's only 2 or 3 women there. There's not enough fellas. There's only one man who's 2, yeah. Okay, the rest of you have to go home tonight and read Alice in Wonderland, all right? That's the deal. But the bit in Alice in Wonderland that fascinates me is when I use a word, it means exactly what I choose it to mean. And this comes back to Hillary's question there about audit versus research. And so many times in healthcare, as we do in Ireland, we use words in a kind of a loose fashion. So I'll be coming back to this time and time again. So for me, the definition of audit is the systematic review and evaluation of current practice against a standard or a guideline with a view to improving patient care. So that bit, we'll hang on to that and come back to it later. But the idea that it is an evaluation. Now, who does the evaluation? We'll address that. But it's an evaluation of current practice. Not what you think you do, what you do against a standard or a guideline with a view to improving patient care. So if it's not doing any of those, well, then it's not really audit. Now, as I said, I'm an orthopod. So for me, I've boiled it down to the essence of simplicity. Do you remember Ronseal? Yes. It does exactly as it says on the tin. When did that catchphrase come out? 60, not quite that much. No, 91. I was only a 2-year-old at the time, but yeah. But what did it say on the tin? Come on, any nerds out there? Ronseal, quick drying, wood varnish. Yes. Now, how do you define quick drying? What's quick in terms of varnish world? It said in a little splash on the side, dries in 4 hours. Most varnishes, most paints took 16 hours to dry. Ronseal quick drying wood varnish dries in 4 hours, does exactly as it says on the tin. So for me, the essence of audit, if you can pick any question and say, are we following what it says on the tin? That's an audit. If you don't know what it says on the tin, or should say on the tin, so simple. But you've now already crossed the first hurdle, like what am I going to do for an audit? So if you are making a statement, if you buy rashers and it says quality Board Bia Irish rashers, they come from Ireland. So simple, Did it come from Ireland? Yes, it did. No, it didn't. It's either or it's not. Now, how many of you here drive? Yes. How many of you here break the speed limit? Okay, this crowd are very honest. This crowd here are having crisis of conscience. If the guard pulled you up and said, you were going a bit faster now, you'd want to know, how fast was I going? And secondly, you'd be thinking, well, what's the speed limit in this particular zone? Am I in a 30, a 50, a 60, a 100, an 80 or 100 or 120? But if the guard just said, no, you were going a bit fast. Well, how fast? Just a bit too fast now. A Kerryman's approach. Yeah. How fast was that? Too fast now. Yeah. You would want to know the exact figure that he caught you at, and you would want to know what was the figure in the little red circle. Simple. So again, you guys have admitted to the fact that you break the speed limit. Does that make you bad drivers? Not necessarily. But you know that you give yourself 1,001 reasons as to why you break the speed limit. Oh, you know, it's the middle of the night and it's straight roads, it's a motorway. I'm in a brand new car. There was nobody else on the road. I'm in a hurry. I'm a really good driver. I'm a doctor. We give ourselves all of those excuses all the time. And then when we're caught, we utter sweet expletives about the person who caught us, like it was their fault, not ours. But the same thing happens in terms of evidence-based healthcare. When we ask ourselves, do we follow evidence-based healthcare? Oh, yeah, well, yeah, I do. Most of the time, yeah. And we know that there are times when we don't follow evidence-based healthcare. And that's where the audit bit comes in, because we know what the evidence is, and we choose or forget or get too wrapped up in something else that we disobey the evidence and we just go off and do it. But we self-rationalize it to ourselves then. Oh, well, you know, this patient was different. Excuse me. Sorry, I probably blew your ears off there. We rationalize why we didn't follow the rules on this particular patient. And you heard it this morning. We blamed the patient. You know, the patient was complicated or the patient just died. Like it wasn't our fault. And we're all guilty of doing that. So this is why clinical audit has become such an important subject. Now, can I ask you then, how many of you use bus lanes when you shouldn't? Now, I don't want a show of hands, all right? But I suspect not many. Now, what's the difference between a bus lane and a speed limit?
Cyclists.
Yes, cyclists, yes. But visibility, yes. You're going to be obvious. But now when you think about it, you're zooming down the bus lane, all these other cars are sitting there stuck. They can't come and chase you. They can go tut-tut. But that's it, and you're gone home. You're going, happy days, lads. Yeah. Penalty. Now, what's the likelihood? Excuse me. What's the likelihood of being caught in a bus lane? Compared to being caught speeding, which is the more likely? Speeding, huh? No, speeding. Oh, yeah, bus lane. Rare enough that you see a guard policing a bus lane.
Shameful, though.
It's
When you're publicly shamed.
yes, exactly. But as well as that, you're absolutely right. You're publicly shamed, but it's clear-cut. And you don't drive in bus lanes because you say it's not the right thing to do. Because you understand the principle of a bus lane is to get volumes of people moving through, whereas the rest of us sitting singly in our cars, we have to put up with the misery. Now, to me, that says something about our practice of evidence-based medicine. Because the reality of it is that you don't really believe that the speed limits are appropriate. Oh, they're too slow. they're, you know, and they don't apply to me. You have that view, don't you? You know, this is you know, the cars are much better these days. But we know the evidence for the speed limit, but we kind of go, no. And the same thing happens in healthcare. We don't really believe the evidence for the safety checklist. We don't really believe the evidence for prophylactic antibiotics perioperatively. We don't really take on board the importance of hand washing or vaccination rates or all of these other things. We kind of do, but we don't fully. Now, audit. Okay, hold the cultured ones amongst you. Who's the man in the middle? Menuhin. God, I'm telling you, that's impressed. Usually in college physicians, they don't get this, but it's a much lower level. Yehudi Menuhin. And Yehudi Menuhin was an absolutely exceptional musician. Now, you could get a computer to play a piece of music that Yehudi Menuhin played. And it would be technically perfect. But it would be a bit soulless. What Yehudi or any other skillful musician or artist brings into it is the whole concept of feeling. And in the same way as you could put a computer in front of somebody in an office, put all the symptoms in, IBM Watson is doing this currently, and it'll throw you back out the diagnosis, but again, that lacks the art of medicine or the empathy of medicine. And so the reality of what made good old Yehudi so good at what he was doing was that he practiced and practiced and practiced. But he also reflected and reflected on how to play the piece of music. And you guys do this every day. You reflect on your current practice. You go home at night and you think, maybe I should have handled that case differently. Or didn't I do a really good job picking up that case of Super Wagga Dogga, whatever it was. You think about your patients probably in the middle of the night. That's the reflection bit. And that's where the clinical audit bit comes into play. Now, when you think about audit, when I think about audit, honestly, when I get an audit report into the office, first thing I do is look at it and see, where did we go wrong? That's what human nature is. We want to see, did we go right or where did we go wrong? And the first thing we're looking at is, where did we go wrong? And talking earlier on about the blame culture, you know, it's human nature to want to find somebody to blame. That's why we buy newspapers. We don't buy newspapers, or we don't read newspapers online to read good news. We read, he won the lotto in Killarney. Now, that's good news for you, but in actual fact, it's bad news for me. So that's the reason why I'm interested in it. I'm not celebrating your wonderful windfall. I'm actually going, should have been me. So, you know, in terms of badness, it's human nature to look for badness. And when we think about audit, we think about it a bit like doing your driving test. You know, he's out to get you. Whereas in actual fact, it's just, again, like any of the exams that we've ever done, from finals through fellowships or through memberships or whatever, we always imagine that the examiner is out to get us. Whereas the examiner is out to pass us. They're helping us out, but we feel the opposite. So that's one thing about audit, but in actual fact, it's all about goodness. It's all about proving that we are doing the right job. And if we're not doing the right job, it gives us an opportunity to improve. So this is a voluntary opportunity for goodness. It also, who talked about MDT working? It's fascinating because it's a wonderful way of getting a conversation going between specialists or between professions or between different groups in the hospital, because it becomes about playing the ball and not the man. I give you a good example from a hospital that will remain entirely nameless. You had a group of nurses who were concerned about the use of reversal agents. and they had no way of bringing up the conversation with the medical team. So they started to do an audit. And then it became about the figures on the table, rather than, you shouldn't be doing it that way, which is what we know would be the other way of conversation that goes on. And you know that that doesn't work, and you know that people shy away from it. Not picking on you, sorry. But it becomes a vehicle to have the conversation. So in the same way, we'll say, as the national figures on hand washing or the HIP mortality databases or some of those big ones, they become the opportunity for you to go back and examine your practice in-house. The other thing too is it's about eliminating waste. Now when I say waste, I'm talking about money, but I'm also talking about your own time. Because if you audit something and you find out that it's actually taking you longer to do it that way than it is to do it this way, there's an opportunity for you to gain a few extra hours. So all of those are the reasons why audit has become a mandatory requirement from those horrible people in the Medical Council. The interesting thing about it is, are you required to do a piece of research every year? Huh? No. No, you're not. And yet we know that most medical CVs, the most important thing is how many papers have you published? How many posters have you presented? How many lectures have you given? And we don't actually require people to identify the audit work they've done. But I have to say, credit to the profession, we are now being asked for letters to verify that people carried out an audit as a student or as an intern or as an SHO when they're going for their interviews, which is a wonderful change. So, clinical audit has to be valued by the profession as an opportunity. And you know the way, like none of us like to have an NCT, but you know it does improve the safety of the cars on the road. None of us likes to have a driving test, but hopefully it means that there are less idiots on the road, but I'm not sure about that one. Now, the recipe. If anybody ever asks you, how am I going to do an audit, PDCA, if you're in the States, it's PDCA, Plan, Do, Study Act, or Plan, Do, Check Act. And you see there, it looks absolutely lovely. It's like pizza quattro stagioni. You know, a bit of planning where you pick your standard, a bit of doing where you gather your data, a bit of checking, and a bit of action. Happy days. Now, sometimes the standard bit can be a challenge. And again, a standard or a guideline. Here's another set of words that we use interchangeably. What's the difference between a standard and a guideline? We use these words every day.
Standard is what you should be doing, a guideline is a suggestion.
Okay, yes, that's actually, you've got it pretty much right there. When you say a guideline, it's a suggestion. How important a suggestion is it? Well, true, but usually it's a consensus statement from a group of experts. So you should follow a guideline. No, you may have some specific reasons not to follow it, but they need to be really good reasons, not just because, I thought I'd disregard it. So you should follow a guideline, a standard you must follow. Now, question for you. Is the speed limit a standard or a guideline? Standard. But we know that this corner down here treated as a guideline. You see, I was at a meeting many years ago where somebody said we have the guidelines for breast surgery, the symptomatic breast care guidelines, and they are called the symptomatic breast care standards. And somebody sat around the table and said, yeah, I know, but I never thought we'd be measured against them. They are standards. They're there to be measured against. Now, sometimes the standard can be a bit hard to find at times. You will always find it. We'll come back to this. But it can be a bit hard to find in some cases. And sometimes it might not even be written down. For instance, for those of you who work in hospital practice, How many patients, what percentage of patients should have a wristband on? 100%. Yeah, happy days. When we started off looking at this, it wasn't actually written down anywhere. Everybody knew it, but it wasn't written down. And sometimes, you may even have to invent your own target. Now, I wouldn't encourage that, but it can happen, and you're perfectly okay with doing it. So it's a bit like, do you remember when you were playing skipping in school as a small child, and two people were holding a skipping rope, and you had to jump in at some stage? Well, you may have to jump in and say, I'm going to pick a target. And that target should be informed by the evidence as much as possible, but it is an option. So don't feel absolutely constrained. Now, I said about pizza quattro stagioni. It looks so lovely there. You know, I'm going to pick a standard. Okay, that might be challenging. Going to gather the data. That's a few hours work here. And I'll probably do the checking while I'm gathering the data. And then I'll do an action. Yeah, easy. It's probably a little bit more like this. A little bit of time for this, a little bit of time for that. That probably done at the same time. And then to make the action. Because how many years have we been working on road safety? And yet we know this whole corner down here. The camera's facing this way, by the way. Yeah. You know, it's hard for us to change our practice, and it's hard for us to change our culture. So it can be incredibly difficult to do an action change or to get that improvement that you want. But, and this is the interesting thing, if you do a plan, do, check, act, if you do the act bit, even a little bit of an act, you're now going to be in a different place than when you started. So instead of it being like a dog chasing its tail, going round and round in circles, it is now going to become a spiral. So you are getting better all the time, and you are slowly but surely improving. Now, this is another issue for doctors. How much improvement would you like to see? Supposing you were at 60, I'm going to pick on you now. 60% you hit the target. We'll say 60% of the time you washed your hands. Not you personally. But so the next time you go around the loop, what do you want it to be? 61, absolutely. Because as doctors, we tend to think, oh, well, we've got to get to 100%, and we've got to get there now. How many of you, on the 1st of January, decide to go out and learn to get fit? And if you're a fella, because it's usually a fella's mindset, you go out on the first night and you run 10 kilometres. And the following day, you get up. Or no, you try to get up. And you can't move. You can't, if you're in the lucky position of having a never-loving partner, you're looking for sympathy. I can't move. It's like having the man flu, isn't it? We don't get sympathy for that either, do we? No. But we look for instant success. Now, one of the biggest challenges with doing an audit, and we find this all the time, is that you go for that instant success. We do another audit in 3 weeks' time or a month's time or whatever, and surprise, surprise, we're at 100%. Now, who's going to tell me the next time round we go from 60% to 100%, where's the next figure going to be? Ooh. Yeah. If you're an economist, and we listen to it every night on the news, you want the economy, if you're the government, you want the economy to grow by? What percent? What's the 3%? Exactly. If it hits 10%, inflation, and people go, ooh, problem. 12%, you're into a bubble, or, you know. So there's a lesson there for us, in the same sense as learning to train for a marathon or learning to become an economist. You want slow, gradual improvement. Now, do not look, or I suppose go for that slow, gradual change over the years. Now, another little thing about the data that you gather. We've already said plan, do, check, act, so you're going to gather your data. Your speedometer. I keep going back to motoring as an analogy because it's something I think most of us can understand easily. Is your speedometer accurate? Relatively. There's a good Kerry answer now. Good Kerry answer. Relatively. That's a kind of that's a more physician's approach to life rather than the surgeon's approach to life. You know, I'm going to straddle the fence here and save.
Correct answer then.
A correct answer, absolutely. Is it over or under? It's over. We'll all go out and check your car afterwards. It's over.
Yeah, you just calibrate it against the monitor, the GPS monitor.
Yeah, yeah. Or even, you know, those flashing signs. Your speed is. Look down at your speedometer the next time.
Always going faster than the speed that they show.
Yeah, that's what I'm saying. Your speedometer is telling you that you're going faster. Yeah, so it's actually reading over, which is of a tremendous benefit to you when you sail past the Gatso van at 187 kilometres an hour. You know, that only happens in Gort. But it's, your speedometer is just an appropriate or approximate, would be the better word, measure of your speed right now. It's not exactly like a GPS. It serves to give you an approximation of what speed you're doing. And that's the benefit of having it, because it doesn't tell you what speed you were doing 5 miles ago. It tells you what speed approximately you're doing now. It's a quick and dirty measurement. If you look at data that we gather for research, it's really, really detailed. Somebody has spent ages working out exactly what data we're going to gather and how precise it's going to be and all the rest. And everybody goes, yawn. Yeah. If it's your PhD or whatever, you're going to be so excited about it, nobody else is going to really care. If you're getting data for external monitoring or accountability, like the hype data or the infection rates or whatever it is that you're sending back into the Department of Health or the HSE, again, it's really detailed data. You send it all in. 6 months later, you get a report back of how you performed 6 months ago. And you go, what's for lunch? Because it's 6 months ago, who cares? It's all done, it's gone. Your speedometer, even though it's not accurate, gives you a quick and dirty approximation of your current speed. So if you're gathering data for audits, you need to feed the results back to people fairly quickly so that they can fix the problem. And they've learned this lesson in the UK because they have national audits. They gather all the data in from the 1st of January to the 31st of December, and then somewhere in March or April they publish the report. And people say, hang on a minute, that's not fair because we're already 3 or 4 months into gathering next year's data before you give us the results of last year's data. So that's a bit like Usain Bolt has walked the first 25 meters. And then somebody says, oh, by the way, you're still in a race, you better run. That's not an appropriate or good way of carrying out an audit. So the data can be quick and dirty. That's a fundamental thing that you can use to your advantage when you're carrying out an audit. It doesn't have to be, you know, it's a bit like measuring the hemoglobin A1C. Is it 6.81? Is it 6.81234? Is it 6.81234.96781? You know, who cares once you've gone past the first digit? Now, that's a picture of Victoria Quay down there by Guinness's. What's the speed limit on the quays? 30. Not on that bit, actually, that's 50. But you're right, it is a 30. So, supposing I was to get a picture of, now it's more likely that offences might occur on this stretch than they would up outside the forecourts, where it is a 30. But supposing I went up outside the forecourts and I started up with my little speed gun, do you think most people keep to the 30? Well, no, well now, suppose we take the traffic out of it, so 3 o'clock in the morning? No. Okay. 2 o'clock in the day, mid-afternoon? Probably not so much either. But between 7 and 8, let's face it, you'd be delighted if we were going 30. Yeah, yeah. Yeah. Now, if we do it at 3 o'clock in the morning, how many cars do you think I would get away with measuring to prove that people do or do not adhere to the speed limit?
10.
Yeah. 3? 3, 4. I'm with you. You're absolutely right. 10. But actually, the bare minimum chances, maybe even 2, but 3 for give us some degree of credibility. Because if you think that people are not adherent, a small number can be measured, and supposing we did 3, and one of them was obeying the speed limit and 2 of them were not, which would be reasonable, we'd say, okay, we were 33% compliant. Now, you could go to 10. Chances are we would still be within 30, 40%. We're not going to get to 70%. You could go to 100. We're still not going to get to 70%. So the point I'm trying to make to you is you get a quick and dirty reading, just like your speedometer, and you say, like as Bill said earlier on, Houston, we have a problem. You stop, and you start to try and improve that problem by 2, 3, 4%. Minor change, and then you go back and you look at it again. So if you think you are not compliant, you can get away with a really small number. If you think you are compliant, well then you have to go further and further and further to find the cases that are going to be an issue. So the lesson, if you're doing your audit for the Medical Council, or for the College of Physicians or Psychiatrists, or for the Faculty of Public Health or whatever, you can do 10 cases. People come into the office, I say, how many are you going to look at? 100? And you say, well, what about 20? Oh, that'd be lovely. So this is about making the audit easy for you. So if you have, we'll say you're looking at the next 10 patients who come into your GP surgery. Did they have their blood pressure checked in the last year? The next 10 patients, next 10 diabetic patients that come into your surgery, have they had their A1C done in the last while? The next, a good one from psychiatry point of view, those who are on lithium should be having their TFTs done at least every 6 months. Next 10 patients through the clinic, has it been done? Either yes or no. Now this is where the Kerry man has to exercise some restraint, because in a situation like that, it's going back to the guard, you were either above or below the speed limit. It's like being a little bit pregnant. There's no such thing. You either are or you're not. Well, maybe for a few hours there's an open period there, but it's an all or nothing. So, did the patient have their TFTs done in the last 6 months? Yes or no. But you see, the trouble is that as medics, we tend to want to give ourselves wiggle room. Well, they had it done in 6 months and 2 weeks. Well, that's like being 61 kilometers in a 60. If it's been accurately measured, you were over the 60. And the traffic cop has every right to bust you. Even though, you know, I love the way people say, but I was only 4 kilometers above the limit. Don't we? We all say that. I was only doing 68 in a 60. You were above the limit. Full stop. No argument. So, lesson number 1, you can make this easy for yourself by doing a small number of cases. You get an approximate as to whether or not you are compliant, and then, if necessary, you decide that I want to do a small improvement. So you go from 60% compliance to 63% compliance or 65% or whatever. Well and good if you get to 70, happy days. But you don't have to get to 100. You don't have to go, oh my God, I have to fix this right now. So, now, you're thinking, how are we doing time-wise? What time is it? 3 o'clock. Okay, grand. You heard this earlier on. Avidas Donabedian's division of quality into structure, process, outcome. And it's a really, really good system. It's very, very easy to remember to look at your care processes. Is it the structure that we have? Is it the care we deliver? Or is it that the patient lived or died? Now, you can see there's a certain colour on them. And the reason that I put that colour on them is that all outcomes, you know, that's what we love to measure. Did the patient live or die? But that can be challenging, because what do you define as an outcome? If somebody has diabetes, is an outcome having their A1C within the normal limits? Or is it the rate of complications? Or is it them having a nice life? If they are depressed, you know, what's a good outcome for that? That they're going around with a smile pasted to their face all the time? You know, it's same with breast cancer. You know, do you measure survival at 1 year, 5 years, 10 years, 20 years? It's challenging to measure outcomes. They can be done, there's no doubt about it, but it's challenging. Structural audits count tangible things, like how many blood pressure cuffs do we have? How many thermometers do we have? How many CT scanners do we have? Because again, tangible things, the more of them that there are, chances are the better the care might be that's delivered. Chances are, not necessarily. And then the important thing in green, the process. So every process of care that you deliver, your prescribing rates, your vaccination rates, your intervention rates, how many of your patients had thromboprophylaxis, how many of your patients who are hypertensive are being prescribed an antihypertensive. Process, if you get the process right, chances are the outcomes will follow, because that's the way it's supposed to work. So, from a structural point of view, number of beds per thousand of population. These bits are kind of hospital-based elements. We'll say the number of appointment slots on your GP surgery, or the number of Snellen charts. So actually, there's a lovely example. There's one that we've just started in Chateau Vincent's in leafydublin4.com, the best hospital in the state. In our elderly assessment unit in Carew House, we are absolutely focused on falls and mobility these days, which is great. And we've done some huge work on minimizing the risk of falling. And then we're also looking at cognitive decline. But one of the OTs came in the other day and said, you know, we're not looking at whether they could see or not. And when she said it, it made such eminent sense. You know, they could be falling all over the place because they can't see 2 feet in front of them. So they've gone off to look to see, have we got Snellen charts around the place? And secondly, if we've got Snellen charts, are we using them? There was a beautifully simple audit. And the simplicity of it is what tickles me. So a process indicator, readmission rates, throughput rates, intervention rates, how many of your patients get whatever the appropriate treatment is, we'll say. And that's unique to your own specialty. And then outcome indicators. Well, you have lots of them, like whether or not if they're disease specific, like your infection rate, or health specific, like the SF36 forms or stuff like that. And performance specific, like how many of your cases are peer reviewed, or what's your lifestyle modification following cardiac events. And then this one here. Now, this is a unique element of clinical audit where patient satisfaction surveys fit in, because they're the one thing that you don't have a standard to go by. Because what is your target in a patient satisfaction survey? That as many people are happy with the service as they can be. But the trouble is, you know that you will never get 100%. There'll always be somebody who's unhappy with it. That's human nature. So, patient surveys or staff surveys are a unique but integral part of clinical audit. Now, David, your point. Who does the audit? Now, you remember your driving test. You had some guy sitting in the car, turn right, turn left, please pull in and do a 3-point turn. You loved every bit of it, didn't you? You still remember it. I mean, does it ensure good quality driving? Probably. It's better there than not there. But do you enjoy it? It's like, apparently, it's something that you have to go through. But is it effective at changing your behavior? I'm not so sure. If you have peer audit, you audit him, he audits you. Do you trust him? You're nodding very gently there. There's an element of, I'm not so sure. Yeah. But, I'm sorry to pick on you now, but the idea is that you know where he has buried the bodies. In every sense of the word. And you know the questions to ask him to elucidate that information. He probably trusts you, you trust him. But if you're doing it as a pair, you know, well, if I'm nice to him, he'll be nice to me, and vice versa. So peer audit is very, very good. It's highly recognized, it's well respected, and it works. But there is a possibility that it can be collusive. And we had an example of that a few years ago. It is a challenge. Now, if you audit yourself, I'm picking on you again now, and you say, you're great, you scored 90%, do you believe him? That momentary hesitation. Now, you see, the interesting thing about that is that if we read in the paper that Ali audited himself and said he was great, I bet you at least 90% of them here wouldn't believe you.
I agree.
Even you mightn't believe yourself. Yeah. But the interesting thing about it is, if you found that you were 60% compliant, who has to make the change? You do. You can have that conversation with yourself, but don't let anybody else see you talking to yourself, or else the psychiatrist will lock you up, all right? But you are motivated to do the change yourself. And the second thing about this, and this is the bit that fascinates me about doctors, we are highly driven, and we are so motivated to be as good as possible. Almost all of us. I dare say you find it hard to find somebody who's not motivated in their heart of hearts to be as good as possible. So we're hardest on ourselves. Because you know when something goes right, I mean, for instance, if you're working in a hospital and somebody comes up, oh, doctor, thank you so much, you saved my life. And you know, if you're standing with the oh, no, it's nothing, you know, we all did it. Yeah, so it's all of us together. But if something goes wrong, who do you blame? If only I had paid more attention, if only I had seen the sign that suggested heart failure, if only I had done. So when things go wrong, we're actually focused on our own failings. So to me, self-audit is actually the most effective, the most absolutely effective way of changing practice. And that's why the Medical Council doesn't say that you have to be peer audited. It doesn't say that you have to be externally audited. It just says you have to do an audit. Because everybody recognizes that we are almost universally driven to be as good as we can be. Now, there's another element to this which follows on from that. I'm going to pick on you, Peter, and you got away lightly. Should I tell people that I'm going to audit them next week?
No,
Okay, why not?
because the process of being audited will make them change their habit, their practice.
Yeah. Now, this is one which is really going to wreck your head. Now, it is said that the Queen of England thinks that all hospitals smell of new paint. Because everywhere she goes, it's been new painted. When Leo Varadkar came to a certain hospital on the south side, which will remain entirely nameless, there were no patients waiting in ED. There's a surprise. Now, 2 or 3 issues on that. Firstly, for those patients that were waiting in ED the night before Leo came, they all got a bed. So from their point of view, hey, come every day, Leo, thanks. So do you remember I said about improving patient care? They won. If the hospital gets painted when the Queen is coming or when Michael D is coming or whoever is coming, Happy Days is going to be painted for a few years. So always look on the bright side of life. Now, Peter, I audited you last week. You know what? Wasn't great. What's your reaction to me, honestly?
You got it wrong.
Okay, you're being very gentlemanly about it. But your first thoughts are probably a number of expletives which you didn't want to say. How dare you audit me behind my back? There's point number 1. Now, Peter, I want you to change, because I think you could be better. The response to that is, you can get on your little motorbike and you can move right on out of here. Because that ain't going to happen. So I have lost you on 2 counts. Now, supposing the guards announce bank holiday weekend. Oh, there's going to be lots of good speed checks this weekend. So any of you heading back down south, you know, oh, I'll drive really safely. Bank holiday Friday, oh, definitely they'll be out. Yeah. Saturday, you're driving around the kingdom and you're kind of going, yeah, it's all grand. Sunday, Monday, coming back to Dublin, you're going to behave because they're going to be out. So it's actually achieved what it set out, because it has kept you behaving for some of the time. Now, if I say to you, Peter, I'm going to audit you next week. It could be Tuesday, it could be Wednesday, Thursday, maybe Friday. You go, oh, right. Tuesday, you're going to be good as gold. Wednesday, it'll cross your mind a few times. Thursday, you will have forgotten entirely about the conversation. So you will be back to your normal activity. So that bit about in research, the Hawthorne effect that I will change your practice. If I changed your practice, wouldn't I have won? So therefore, I should be telling you. And secondly, if I have told you in such a way that you don't know what day it's going to happen, well, then you're going to behave normally anyway. So I still may win. So in opposition to research, I should tell you beforehand that I'm going to audit you, which is something that we find extremely difficult to get our heads around. How are we time-wise? Okay, we're going to. Yeah. A teeny bit. Which in space terms, do you remember the movie Airplane? Space terms is 500,000 miles. Yeah. Now, I'm going to move to and finish up on to... when you audit people, you think that they get better? Not always. This is a Cochrane review from 2006, but still as valid. You know, most people get better. Some people get worse. And we've had loads of examples of this. People go, I'm not doing that. No matter how much you think you can make me, I'm not doing it. So that gets back into the change bit. And so, good audit. Good audit is about auditing. Who said earlier about picking the right stuff? And if you're thinking, what am I going to audit? One of the suggestions I would give you, pick the stuff that pisses you off. Because that's the stuff that you'll be really interested in. And you'll now have evidence to go and wave in somebody's face and say, we need to fix this. So that's one thing. In terms of, where was it? The relevance, yeah. So pick something that's easy to do, that's interesting to do, and that might make your life a little bit easier. So it's all about continual self-improvement. Remember, the audit is a journey, not a destination. So understandably for all of us, you want to tick the box on your annual declaration. Did you do an audit? Yes, I did. Thanks very much. That's one aim, but the other aim is about improving. And then the last thing is about how you are going to get the right actions followed through. Because sometimes you can audit stuff and get a wrong direction. We had a chat at Grand Rounds about hospital standardized mortality rates. They can throw up the wrong information, the wrong data, and it lead to gaming of the system. So just think about what you're auditing. Now, I'm going to finish off. By the way, the slides are available for anybody who wants them. The last 2 points that I'd want to make is that when you have concluded your audit, you should have a series of recommendations. Now, if you audit it yourself, essentially that's a conversation that goes on in your head. You don't need to write it down. But the bit that fascinates me, and I see it all the time when people write posters for conferences, and their first conclusion is, more research is needed on this topic. That's the bleeding obvious. That's Homer Simpson, though. You know, that's not a conclusion. We all know that's to be the case. More forms. Again, I work in, and I not just work in one institution, but I have been involved in other hospitals around the country, and people say the answer is a checklist. And that's grand, but then you have a checklist, you have a checklist, you have a checklist, and you have a checklist. Whose checklist is the most important? So just think that one out. Your responses should be, we or I will do X, Y, Z in the next how many weeks, 6 weeks, 8 weeks, whatever it is. And how will I know when I got there? You'll do another audit. Now, every religion in the world has a list of rules. And if you're Muslim, you have the 5 pillars. If you're a Buddhist, you have the 3 ways. If you're a Christian, you will have the 10 commandments. So as an example, I have modified the 10 commandments slightly here. All right? So do not confuse audit and research. We covered that with Ron Seal. Close the loop. In other words, do some action. Any little action. And even if it's only getting a 1% improvement, you're winning. Keep it simple and have a plan. You do not need to make this difficult. You don't need stats, for instance. You can do it with a pencil and paper. You do not need to collect needless data, because you know that we all say, oh, well, I'm at it now. I'll gather extra data because I might get 2 audits out of it. Tell everybody in advance about your audit. And again, don't keep the information longer than you need it, because audit is subject to freedom of information. You gather the data, you anonymize the data, even if it's only 10 cases, and then you compile your audit report. And then lastly, re-audit, because that's what's important. Does that make sense to you guys?